We're going to talk about alcohol use and alcohol-related cognitive dysfunction in older adults and the clinical implications. So I'll just introduce myself a little bit. So my name is Lori DiBlasi. I'm currently the postdoctoral fellow at UConn Health in the psychiatry department, and I work with the neuropsychology faculty. I got my graduate degree from William James College in Newton, Mass, with a concentration in neuropsychology. I did pretty much all of my practicums and training in neuropsychology, mostly with adults and older adults. My passion is really working with older adults. Did my internship with adults and older adults in Staten Island at a rehab hospital. And like I said, I'm finishing up my postdoc here at UConn. That's a little bit about me. So we'll start with the presentation, and there should be time for questions if you have any questions, but we'll see how it goes. All righty. So just kind of the objective is to just talk broadly about alcohol use in older adults, the cognitive implications, behavioral and emotional functioning. I think really it's kind of brief because I could spend hours and hours, maybe a whole course, talking about this topic. So I really want to emphasize kind of maybe some key points that we can use in clinical work, just to provide some type of foundation for us who see these types of clients and patients in everyday life. Okay. So there will be some questions at the end, or that you'll receive after the presentation is over. So I just wanted to highlight those for you. So the first question is, older adults who take which of the following medications are at increased risk of hemorrhage when consuming alcohol? Older adults who meet criteria for alcohol use disorder may have increased risk of relapse due to cognitive dysfunction associated with the following domain. And finally, blank is a common symptom of Wernicke-Korsakoff syndrome. So keep those in mind when we're going through the presentation. All righty. So I'll just start with a brief overview of the aging population, and the term I use throughout this presentation is older adult. And what I mean by that is we typically use that to refer to someone who is 60 years of age or older, though this can vary in different contexts, by different states, by different laws, and different situations. Most of the research, that's what is used, but even in some research studies, they may choose to include people that are 50 or 55. So just something to keep in mind. This is a growing population. So by 2050, they're expected to reach 2.1 billion older adults in the world. And in a 2021 survey by WHO, there was already over 1 billion individuals who were age 60 or older worldwide. By 2030, excuse me, 1 in 6 people will be over 60. So this is a large portion of our population. And this wasn't always the case. The hypothesis is that due to advances in healthcare, nutrition, disease prevention, that this accounts for the growing nature of this population. So let's just get a little bit of background on alcohol use in general. So among individuals 12 years or older in the 2023 SAMHSA National Survey, almost half of those people, a little bit under 50%, drank alcohol at all in the last month. And that's almost 140 million people. But this use was highest in individuals age 26 or older. Excessive drinking, we know, is associated with significant morbidity, all-cause mortality, and is one of the leading causes of preventable deaths worldwide. Individuals engaged in high-intensity drinking, which is having more than the gender-specific amounts, which we'll talk about in a second. Those individuals were more than 70 times likely to present to the emergency room with alcohol-related visits. And it contributes to 88,000 deaths annually in the US, according to this 2018 study. It also increases your risk for stroke, motor vehicle accidents, head traumas, seizures, heart disease, infarctions, a lot of things. And there's different types of drinking. So in this diorama, you could see that they're talking about binge drinking. And that has to do with having, again, more than the recommended amount for your gender or sex at least one day in the past 30 days. So for men, that's 1 to 2 drinks a day is the recommended amount. So anything above that is considered excessive. And for women, it's really 1 drink a day. And this is really different for older adults, where the recommendation is no more than 7 drinks kind of across the board. So that's really like 1 drink a day. And that's for people who don't take medications that have potential interactions with alcohol. And I think this graphic is important when you're working with clients and patients, when you're asking how much are you drinking. It varies by what types of alcohol and drinks that they're drinking. So are you drinking 12 ounces of beer? Is that a drink? Or are you having 18 ounces? Because that's really more like 1.5 drinks. 5 ounces of wine, or are you having a generously poured glass of wine? Those are some things that you can ask in interviews, not in a way of judgment, but just to kind of evaluate, their risk for the things that we'll end up talking about. So I think that's important because you can say, I'm only having 1 or 2 drinks. But if you're having an 8-ounce glass of wine, that's really more than 1 drink. So that's helpful to understand. So just a little bit of background on alcohol use disorder. I'll go over this briefly. I'm sure many of the people on this Zoom are very aware of this. And this is really a pattern of problematic drinking, according to the DSM-5, that leads to clinically significant impairment or distress in everyday life. And these are the criteria. But something, to qualify for this diagnosis, you have to meet at least 2 of these diagnostic criteria. And I just want to emphasize that not all individuals who engage in risky or heavy or excessive drinking qualify for a formal diagnosis of alcohol use disorder. And throughout this presentation, we'll talk about risky drinking, excessive drinking, and alcohol use disorder, though these aren't really used interchangeably. So really, alcohol use disorder is somebody whose drinking is considered problematic because it impacts their daily functioning. Okay, let's now talk about alcohol in the brain. So when somebody drinks alcohol, we do see biological changes in the brain. And the most vulnerable networks in the brain are the frontocerebellar system. So this is the system that connects the cerebellum right here. I'm not sure if you could, or over here, you could probably see my cursor, the cerebellum here to the frontal cortex and the mesocorticolimbic cortex. And the mesocorticolimbic circuitry is really important for connecting things to the prefrontal cortex, which is important for things like attention, executive functions, motivation, and that will be important for things that we'll discuss later when we're talking about cognitive dysfunction related to alcohol use. So just general degradation of white matter is in again, the prefrontal cortex, the corpus callosum, which is the structure that connects the 2 brain hemispheres and allows them to communicate with each other, and the cerebellum here, which is responsible for things like coordinated movement, intentional movement, balance, posture, things like that. Which is why if you're under the influence, you might be off balance or you have a different kind of walk, almost like a toddler. We see neuronal loss in more frontal areas, the hypothalamus, and again, the cerebellum. The more alcohol consumed, the greater likelihood of atrophy or the loss of matter in the brain. There's some conflicting evidence about moderate drinkers, but the hypothesis is where it almost might be a protective factor. But the hypothesis is that in these studies, the individuals who were moderate drinkers and performed better were of higher SES and may have also a higher chance of having more cognitive reserve So their brains are a bit more resilient to the effects of alcohol or other types of brain injuries or pathologies and things like that. Um, and good news is in abstinence, we can see increases in volumes in the hippocampus, which is implicated in forming new memories, the brain in general, so the cerebrum, and again, the cerebellum. And this is an image that just shows where you can see really clearly that this is the cerebellum in a healthy control. It's nice and full. And then this is an individual who was diagnosed with alcohol use disorder. And you can see that it's much smaller and you can see more of the folia, meaning that the matter there has shrunk because it's atrophied. And this is just another image showing the brain of a healthy control. So this person is 63 years old. Their brain looks nice, it's full. This is somebody that was, again, meets criteria for alcohol use disorder. And we can again see just in general, it's a little bit more atrophied. You can see by the widening here. Oh, I forget my mouse is over here. So the cerebellum again is a bit more atrophied here. The corpus callosum over here is more atrophied. And then this is an individual who is diagnosed with what we'll talk about a little bit later, which is called Wernicke-Korsakoff syndrome, which is a more severe form of alcohol use in the brain. And particularly here, you can see that this is nice and full. So the ventricles aren't as wide. And here, from here to here, you can see they're getting a bit bigger, meaning the brain is atrophying. And here they are the largest. So this has caused the most atrophy. Okay. Let's talk about alcohol use in older adults. Alcohol, excuse me, is the most commonly used substance in older adults in the United States. About 30% of older adults who engage in risky drinking develop these patterns later in life. The reason for that is some research says, this could be associated with bereavement, physical health problems, lack of mobility, and social isolation and depression, which all of these factors increase as we age. Alcohol use decreases with age in general. That's the pattern. It's really interesting, though health and other risks that are increase with alcohol use as you age. And there's been kind of this pattern recently that actually alcohol use in older adults has been increasing over time. So over a 71% increase in the last few decades of older adults using alcohol, kind of in a risky way. In this study from 2020, it shows that 4 to 14% of older adults may misuse alcohol. Studies show that older adults that consumed alcohol in general had more recent healthcare visits. Moderate use is, again, your increase for a multitude of health problems, high blood pressure, sleep problems, malnutrition, and a greater increased risk for falls. And falls in older adults are associated with more adverse outcomes than in younger adults. So it's very important to think about this. Older adults metabolize alcohol less efficiently than younger adults as well. They have less lean body mass, they have smaller water volume, and that's why an older adult and a younger adult can drink the same amount, but the blood alcohol level in an older adult will be higher and will stay higher in the older adult than the younger adult. So that's another area to discuss with a patient because this person could be drinking, well, I've always drank 2 or 3 drinks a day my whole life. Well, now that you've aged, you're metabolizing it differently and it can impact you in different ways than it did 20 or 30 years ago. In general, there's a higher risk of drug interactions and adverse drug interactions because of the slower metabolism and clearance in older adults, but also because older adults are more likely to be prescribed more medication than younger adults. Just a brief, there's many different types of medications that can interact with alcohol, but some of the ones that are quite common and might not be talked about are anticoagulants, which are your blood thinners. They elevate the risk for bleeding or hemorrhage, particularly in older adults. And benzodiazepines, which are sedatives like Valium, Xanax, things like that. They're sedatives, so they sedate you and they increase risk for cognitive difficulties, both in the acute stage and chronically over time, and falls, and then the related injuries, amongst many other types of things. Now I want to talk about cognitive functioning in older adults. There's a normal aging process that we see over time. Um, Sorry to burst anyone's bubble, but we start declining actually cognitively even in our third decade. So when we're in our 30s, we start declining in areas such as processing speed, so how fast you can process information, executive functions, things like multitasking, problem solving, planning, kind of like the executive of your brain, memory, and visuospatial skills. And these abilities do exhibit a very small but consistent decline over time, but this is normal and expected. So that's important to know. And then even in terms of brain volume, we do see a normal amount of decrease in overall white matter volume, even in older adults. Some of the studies, though, are limited by normal controls. So there is an expected decline in these functions, and I think that's important to know. This is just a graph showing that individuals starting at 74 to 84, they do decline. So you might not be able to remember as much, you might not have as good of a vocabulary, you might be slower, but there is an expected normal decline in these abilities. And I'll talk a bit more about that when we're talking about neuropsychological tests and how we evaluate what's normal and what's not normal. And then there's more than age expected decline. And you might have heard these terms before. These are diagnostic terms, so mild neurocognitive disorder and major neurocognitive disorder. And these aren't pathologies or etiologies. Sometimes, the word dementia or these diagnoses are used interchangeably with like Alzheimer's disease. But these are more diagnostic criteria based on how impacted the person is by these cognitive difficulties. So it's really based on functional abilities. And these do reflect a decline that is more than expected for age. So this is an abnormal decline. Mild neurocognitive disorder is a decline in cognitive abilities more than what we expect in the normal aging process. So this person has impairments in differing areas of cognitive functioning, but they're still able to independently manage their activities of daily living. So things like paying their bills, managing their medications, driving, cooking, kind of without any concern for safety or mistakes or anything like that. And then there's major neurocognitive disorder, which is the same thing as the word dementia. And this is a decline in cognitive abilities, again, more than what we would expect for age, but you also have a functional decline. So those individuals that meet criteria for this need help or assistance, or they're dependent on others for things like, again, they might have trouble remembering to take their medications, so they need someone to remind them or organize their pills. They might have unsafe driving because of memory or attention or any of those things. They might leave the stove on, burn food. And again, this is more than it is expected for normal aging. And major neurocognitive disorder, which again is dementia, the severity is mild to severe. Sometimes I think a visual is easier to talk about than talking about it in terms like this. It can be kind of confusing. So in this graph, we can see that this line here represents somebody that has functioning with no cognitive impairment. And then they started to decline. And this red line here that I drew very beautifully shows a functional threshold. So everything above this red line, this person can function independently. So this person has declined more than expected for age, but they are functionally independent which would qualify them for a diagnosis of mild cognitive impairment, which is used interchangeably with mild neurocognitive disorder. Now this person continued to decline, and they've now are lower than the functional threshold, so they need help with those activities I just mentioned. And so now this person would qualify for a diagnosis of dementia. Again, the word dementia does not mean Alzheimer's. I think it's, again, used all the time interchangeably and can be a kind of scary term because of that. Alzheimer's disease, just to clarify, Alzheimer's disease is the most common cause of dementia in older adults, but it is not the only cause. So you can have dementia for a number of reasons. If you had a stroke, you had a traumatic brain injury, you have Parkinson's, other types of dementias, maybe from alcohol use, things like that. So I think that's important to establish, especially because the word can be scary when you're talking about it with patients or clients. So now let's talk about alcohol-related cognitive dysfunction and dementia. So we know, as we just talked about, alcohol use accelerates brain aging and contributes to cognitive impairments and also increases your risk for developing dementia. And so some of the studies show that in general, there's some sparing of like your general intellectual abilities and some language abilities outside of some retrieval and speed difficulties. So difficulty retrieving the word, even though you might know what the word is and what the word means. So that's not really a true language difficulty. That might be more of an executive difficulty. We do see deficits just in alcohol, excessive alcohol use. You don't have to meet criteria for alcohol use disorder to see these types of deficits in clients or patients. So we see the deficits in attention, processing speed, and executive functioning. And when we were talking about the brain before, a lot of the areas that were particularly vulnerable to alcohol use were in the frontal lobe or the prefrontal cortex. And that area is primarily responsible for these types of functions. So it's no surprise that you would see difficulties in this area. The visuospatial abilities, such as the ability to kind of like copy a figure, to judge spatial relationships, visual perception, those are a common finding in alcohol use, cognitive related dysfunction. We do see memory difficulties, but this is much different than the memory difficulties you might see in Alzheimer's disease. So memory deficits are typically driven by difficulties with executive functioning. So the person, if I read them a list of words, they might have trouble encoding it. They might learn fewer words and have trouble freely recalling those words after 20 minutes. But if I say, what were all those words on that list that were vegetables? I'll say, oh, okay, they might be able to pull that out with the benefit of a cue. And if I say, was carrot on the list, yes or no, they can recognize it. And this is much different than other types of memory difficulties, like in Alzheimer's. They might learn it, but they wouldn't be able to consolidate it, so they would lose it all. So this is really like what we would call an executive type memory profile, except in a Wernicke's encephalopathy and syndrome, which we'll talk about, where there is dense amnesia. Procedural memory is spared though, and that's memory for things like how to ride a bike, how to drive a car, things like that. And then we do see deficits in decision-making and social cognition, so being able to process emotions and impulse control. And again, kind of like what we talked about with the brain being susceptible to alcohol, but being able to kind of bounce back in abstinence. We do see that also on neuropsychological measures that individuals who did maintain sobriety for 7 years, improved and performed as well as healthy controls. And an important thing to know about neuropsychological measures is performances are compared to age-matched controls. So they're able to make those comparisons. So if somebody takes a test of attention or memory and this is their score, you're able to say, this is exactly where we would expect this person to be for age, or this is well below what we would expect the person to be performing at for their age. And that also informs the mild neurocognitive disorder and major neurocognitive disorder. Emotional outcomes, there's an increased risk of depression, anxiety, apathy, alexithymia, things like that. So I've hinted at this a few times, so let's talk about Wernicke encephalopathy and Wernicke-Korsakoff syndrome. This Wernicke encephalopathy is an acute neurological condition caused by thiamine or B1 deficiency. And this can be caused by individuals who engage in excessive drinking or alcohol use disorder, but it can occur from any other type of disorder or situation that can lead to malnutrition, like very severe malnutrition, like individuals who've undergone bariatric surgery, certain eating disorders, hypothyroidism, and alcohol use disorder. The thiamine deficiency is associated kind of with lifestyle factors because the alcohol use compromises thiamine absorption from your gastrointestinal tract, excuse me. So you're unable to kind of store that, which then leads to the deficiency. And again, this is an acute phase that requires kind of immediate treatment. And what you can see, there's a clinical triad, which is ophthalmoparesis, which is essentially abnormal eye movements, nystagmus, ataxia, which is difficulty with coordinated movements, again, related to the cerebellum, and just general confusion. Like I said, we really needed treatment kind of as soon as possible, and it's really just administering thiamine. Because if it's untreated or unrecognized, you can develop Wernicke-Korsakoff syndrome, which is a chronic condition. And this is a more dense amnesia than what we were talking about before, when you can have difficulties with memory, but you might be able to recognize, or you might be able to get something with a cue. Individuals who meet criteria for Wernicke-Korsakoff syndrome have a dense amnesia. And you still see this clinical triad, and something that can be seen in Wernicke-Korsakoff syndrome is confabulations. It's a neuropsychiatric disorder where a patient kind of generates a false memory, but they're not meaning to lie. So I've seen patients with Wernicke-Korsakoffs who are in an inpatient facility I forget what it was for, but for some type of neurological event. And they were telling me, yes, they just came in from work and they were working with their partner. They used to be a cop, and the person was in the hospital for a very long time. But this person was not intending to lie. They truly believe this, and they're generating this memory. So this is something that is pretty specific to Wernicke-Korsakoff syndrome. And then I think it's important to talk about depression as well when you're talking about alcohol use in older adults and cognition. Depression is one of the most common co-occurring disorders amongst older adults with alcohol use disorder. Older adults who misuse alcohol often report depression kind of as the antecedent to those behaviors. And older adults who reported higher levels of depression were at greater risk for alcohol problems. So this is kind of a multifaceted, cyclical issue. It's oftentimes hard to unravel. Alcohol use depression and those who consume alcohol and have depression are just at increased risk for cognitive dysfunction and dementia. Drinking alcohol can worsen depression, which can worsen cognitive functioning. Having depression can make it harder to stop drinking alcohol. And what we'll talk about in a second is having cognitive dysfunction can also put you at increased risk of relapsing or risky drinking in general. So when we're thinking about clinical implications, so cognitive dysfunction associated with drinking, which we talked about before, which were those difficulties with attention, executive functioning, speed, memory, things like that. Well, those deficits, specifically people that have trouble with executive functioning, so they're a bit more impulsive, they have poor decision-making skills, those difficulties promote a higher risk for relapse. And identifying those difficulties in older adults can help promote better outcomes. Depression, anxiety, poor coping also elevate risk for relapse. And some literature suggests risky drinking. It should also be areas of treatment, so treating comorbid psychiatric disorders. Relatedly, cognitive dysfunction can decrease motivation to decrease or abstain from drinking alcohol, which can be amplified by depressive symptoms. So, like I said, this is kind of a very multifaceted issue. This visual here just shows that these different areas of cognition make it hard for somebody. They're obstacles to alcohol treatment. So, decision making, should I have a regular drink or not? Social cognition, not being able to be aware that that drinking is getting in the way of interpersonal functioning, motivation, again. So this is just, I like this visual because it just shows all of these different areas of cognition which can be impacted in alcohol use, also present as obstacles to treatment. Older adults, just thinking again in general, older adults are generally at higher risk of having lack of social support and then also related negative impacts, social isolation, loneliness, factors such as retirement, decreased physical ability, loss of loved ones, and living alone contribute to this. And these difficulties can be amplified by alcohol use and psychiatric factors and depression. Again, all of these things can be related. Older primary care patients are more likely to accept mental health treatment within a primary care setting than in outpatient mental health and substance use clinics. So this begs the need for a collaborative care and a multidisciplinary approach, and hopefully having a relationship with primary care settings who do see older adults who can make those appropriate referrals, because they may be the first line that older adults come into contact with, who can identify these risk factors. And prevention and early identification is key in providing timely treatments and reducing negative outcomes in this population. When we're thinking about treatment and resources, alcohol use in older adults, just checking the time here. There's widespread screening, and healthcare and behavioral treatments can assist with identifying risky drinking or older adults who may meet criteria for alcohol use disorder, so that you can get them treatment or refer them out to treatment services. There's a few screeners that we will talk about in a second that can assist healthcare and mental health care professionals identify the need for intervention or referrals or education in older adults. There's some evidence that at-risk older adult drinkers, that more intensive interventions, such as getting personalized feedback about their drinking habits, providing education, and follow-up telephone calls. So someone kind of keeps calling you, following up with you over time, and advice from a physician. Those show positive outcomes in improving alcohol consumption in older adults who are at risk. Brief interventions within primary care settings, as we talked about, emergency departments, older adult focused services, outpatient behavioral health care programs can all provide interventions. There's support groups such as Alcoholics Anonymous, Emotional Anonymous, and just there's also a need to identify or referring those who would require medical treatment as well. As we know, withdrawal and detox from alcohol can be life-threatening, and so identifying those individuals who would need that level of care is really important. Raising a red flag or older adults that you see are taking medications that can interact with drinking, and being able to refer to specific providers who can help with that. Excuse me, that would include geriatricians, geriatric psychiatry, neurology, someone who can really consult on the medications. Just in general, helping the older adults establish healthcare providers who can help them with mental health and treating any co-occurring psychiatric disorders. So again, maybe the person doesn't even have a PCP or a geriatrician, and connecting them with those services. Here's a few specific techniques that have been shown to be effective. Motivational interviewing, actually cognitive behavioral therapy, CBT, social skills training, skill-based approaches. Those have been found to be effective in older adults. Here's a few screeners that are commonly used and have been found to be effective in identifying alcohol problems in older adults. This is the audit, which was made by the World Health Organization. The scores range from 0 to 40. This can be helpful in kind of qualitatively and quantitatively seeing at what risk level an individual is for risky drinking. Like I said, the scores range from 0 to 40, with higher scores suggesting a greater need for intervention. The MASG is a specific questionnaire targeted for older adults. So the MASG stands for the Michigan Alcoholism Screening Test, geriatric version. It's 24 questions. It's just yes, no. An answer of yes 5 or more times, could suggest that the person might need further assessment, one, and may qualify for treatment. The cage, these are kind of older as well. I will point that out. This is from 1995. The cage can also be used in older adults. It's only 4 questions, and again, yes or no, and just having 2 or more yeses is, the potential of somebody that might need more help and need more assessment. Now, treatment resources for cognitive dysfunction. Again, I mentioned this before, but established, so individuals who have identified cognitive dysfunction, or we may be questioning if they have cognitive dysfunction or dementia, establishing care with somebody who can follow them over time. So that might be a geriatrician, a neurologist, a geriatric psychiatrist, who could talk with them about treatment options. This could be medications, this could be non-pharmacological approaches. You might want to get a neuropsychological evaluation to either evaluate, is there cognitive dysfunction? Is this related to alcohol? Is this something else, like an Alzheimer's or something else? So that's why neuropsychological evaluation can be helpful and guide treatments. Physical, occupational, and speech or cognitive therapies can be helpful. And social work is great for identifying available resources for older adults, because we talked about their increased risk for loneliness and social isolation. So they may not have a caregiver or someone who can assist them with those daily living tasks. And then that becomes unsafe and can lead to further difficulties. Social work can also help identify resources for caregivers and find resources outside of caregivers. So some in-home help who can support activities of daily living and future planning, if in the future they need a different living situation that would support them and their safety. That can also be, social work can also help with that. Just in general, unfortunately, it's all of the things that we've ever heard from any doctors is exercise, eating healthy, and staying busy are really good for the brain in general and healthy aging, but also for individuals who have cognitive dysfunction, so slowing decline. Regular exercise within the bounds of safety, as monitored by your physicians. So individuals who have pain or have mobility issues, there's water exercises, there's even physical therapy that can be done in a pool. Exercise is really consistently shown to be one of promote the most positive outcomes, more than these other things that I'll talk about. So exercise, eating a heart healthy diet. What's good for the heart is good for the brain, and regular cognitive and social stimulation. So, we get a lot of this because we're working and we're in social situations, but after retirement, you're not being stimulated each day and you're likely not getting social stimulation because you're not at work. So finding ways to remain cognitively and socially stimulated, like through local senior centers, just doing puzzles, games, building into your schedule to have plans with friends or family, learning new tasks, knitting, learning a new language, music, all of these things that just stimulate your brain can really promote, again, brain health and slowing cognitive decline and reducing stress, as always. The main takeaways are that alcohol use in older adults is a very complex and multifaceted issue and is often overlooked in healthcare settings. Excessive use, risky drinking, and alcohol use disorders in older adults can impact brain structures, cognitive functionings, and mood, and the interplay between these factors is difficult to unravel. Awareness of these factors and difficulties in this population is key in providing timely treatment and appropriate referrals. And even though resources exist, additional research and programs are needed to support this population and their needs. And take questions. I have a bunch of references as well. There's a lot of research on that. I can end slideshow and open it up for questions.
Hi, do I just speak up? Um, Thank you for the presentation. It was really, really good. I've got a couple of questions, but from the beginning of the presentation, I was wondering, you said the same amount of alcohol due to the different metabolism has a different effect on older adults. Where does tolerance come in there? Because obviously tolerance builds up sort of over time. Is there sort of a specific age at which, or is that a gradual thing? Because obviously functioning alcoholics, they would have built up quite a bit of tolerance over time.
No, that's a good question. I'm not sure about the age exactly, but your tolerance does change as you're older because of the blood alcohol content, not the blood alcohol tap content, but your metabolism changing. So your tolerance, if you're somebody that consistently drinks, you're going to be able to maintain that tolerance. But for older adults, kind of outside of, I assume you're talking maybe more about people that might have alcohol use disorder who are chronically drinking at a certain amount. So in the research that I'm more familiar with, it's just like adults who might drink one or two drinks here and there. Their tolerance changes over time. So if you were, when you were 30 and that was, that had no impact on you, it's going to have a different impact on you now. But it does, the research shows it does change tolerance because of these biological changes in your body's ability to metabolize the alcohol. And it might even have more of those silent impacts that I'm talking about. So those changes in the cognitive functioning and the brain structures, even if the person on the outside doesn't look like more intoxicated, they can still have these brain and cognitive changes underlying those things.
Thank you. I've got another question if nobody else. Um, so you said you talked about the atrophy in the brain. Again, do you have like a time period of over how much time does this sort of occur? We're talking like 5 years or 10 years, or is it much shorter than that?
That is again a really good question. I'm not sure about the time
Okay,
period,
sorry.
but no, these are really good questions. But I think the takeaway for me, and these are things that I can include in this presentation if I were to do that again, is that you're at increased risk of the more you drink, the more likely your brain is to atrophy over time, and the more likely it is if you're older, and not even for individuals that meet criteria for alcohol use disorder. So anyone who, 7 drinks a week is 1 drink a night. So this is
Yeah.
individuals are like, I have a glass of wine with dinner. And that's not necessarily what we would think as risky drinking. But those individuals over the age of 60, they still do show that you can show those brain areas of brain atrophy over time. I'm not sure about the timeline though. That is a good
No, that's
question.
fine. I mean, we use the audit with clients, and they tend to be criminal justice involved, and they tend to have been drinking for a longer period of time.
Hmm.
What it comes with, the little infographic of how much is a unit of alcohol
Yes.
in pictures, and I always find I see the eye-opening moment when they're like, oh, okay, because as you say, your glass of wine might not be my glass of wine, and they're like,
Hmm.
oh, well, okay. So yeah, that is, but it is helpful because a lot of the people who've been drinking for a number of years are like, well, I've built up a tolerance and I don't feel it and it's not that bad, but
Hmm.
obviously it is.
And just in terms of like maybe talking about with them in terms of like risk, like you can't ever be sure, but you could say, drinking this way is a risk for these types of things and optimizing like your brain health, your cognitive functioning, drinking this way is a risk for changes in your brain and changes in your functioning. Um, I think that's not often talked about. And I think again, 7 drinks,
Yeah.
that's really not that much, but that amount is associated with brain changes and cognitive dysfunction in older adults, even though that's not that much on a
Yeah, yeah, yeah. It's also socially tolerated, isn't it?
spectrum.
It's I,
Yeah.
I always say in training, if I said to you at the end of the night, oh, I'm just going to do a line of Coke, um,
Mhm.
people would be like, oh my God, that is
Yes.
shocking. But if I say I'm going to have a glass of wine to relax with, people are like, oh yes, that makes sense.
Mhm.
Had one more question if nobody else is
Go
putting
for it.
in. You said primary care settings are sort of the best place for older adults to access um help with drinking. Do you know why? Is that a stigma thing or accessibility or?
I think the hypothesis is the stigma. It might not be the best, but it's in this study that I found it was they were more likely to accept help from the primary care settings. And I'm not sure if the study, I can look for it again, if they're just more frequently going to those type, like more older adults are more likely to be accessing primary care settings than mental health settings. I mean, just anecdotally, can't say that word, sorry. Um,
Right.
we know that like psychiatric medications in general,
Mm.
80% of them are like prescribed by primary care providers
Yeah.
and not by psychiatrists. So there's definitely that stigma in general, which is both good and bad because there's also huge wait lists for psychiatrists and for mental health care because there's such a huge need. So we do need somebody who can provide that care, but there are these more specialized services. So it's like this catch 22 almost of we need them, but are they the most specialized in helping them and optimizing them in the way that they can?
No, but that is a really interesting point, and I really like that you made that in the presentations because we tend to refer people to drug and alcohol centers, but it's sort of a self-referral unless they meet sort of the clinical threshold for alcohol use disorder. And now I'm thinking, might the routing be better if we send them to the primary care physician instead? Um,
There's many collaborative clinics. I'm not sure of any like off the top of my head where they have the mental health professionals embedded in the primary care clinics, or geriatric clinics that have
mm,
like memory care embedded in them, and maybe coming out of it more as like a health standpoint might help reduce the stigma. But this is like personal anecdote in terms of that.
yeah, I'm UK based and Germany based, and it works a little bit different here anyway. But
Mhm.
we do tend to sort of refer to specific centers, and we have wondered why the uptake hasn't been as great. But stigma makes a lot of sense, to be honest. And I was thinking maybe accessibility as well, in
Yeah.
terms of it's somewhere else, isn't it, rather than, as you say, where you normally go. Okay,
Just
that's
having
really
eyes on that person, just like
yeah.
need some type of someone who's looking at their health and their mental well-being. Because if they don't have anyone, like no one's gonna be able to say, here's a resource or here, try this, or
Mm,
this is someone that can help you.
fabulous. Thank you so much.
Absolutely. Thank you for your questions. Any other questions?
There's one in the chat. I don't know if you can see
Oh,
that. It says about insurance impacting options.
That is true.
So one other one other question, I'm sorry.
That's okay.
You said, so is the Mass G, would you rate that higher for older adults as opposed to the audit?
Um, Let me see. I think I put the sensitivity and specificity on here. So the problem with the Mass G, why I included it is it's specifically tailored to older adults. It's one of the only things that I could find was like, this is made for older adults.
Yeah.
But it's quite old, I will say. It's
Okay.
1995. It has good sensitivity, 93%, but the specificity is it's like 65%.
Okay.
So it's older than the audit.
Yeah.
Let me see if I put the sensitivity for the audit. Um, you know, the audit is not the newest thing either. Um, and they did study the audit in like college populations, older adults, women. There was some research that showed the audit was better at identifying these problems in men. Um, so there was some studies that suggest, well, there might need to be different versions of the audit for women or older adults. So for different populations that might be better at identifying in these populations. Um, I just think the audit is like more common and more well used, and
Yeah.
that's
That's why we use it
that's what
because
I've
it's,
used.
yeah, it's clinically here. If you make a referral, they will either redo it or not accept what you've
Okay, yeah.
what you've sent. So that's why we use the audit. They do have now sort of a statistics for women because we at the moment we specialize in women.
Oh,
Um, so they did it with veterans in the US though, which is also a very specific group. But no, I accept that. That's fine. I was just wondering if maybe for older adults it should be maybe a bit more tailored. So if somebody comes in,
mhm.
like their assessments just tailored rather than the audit they did.
Yeah, and these are just like yes, no questions, which sometimes can be easier. This is again something that I've just drawn from clinical
Yeah.
experience. Sometimes yes, no can be easier in older adult populations than like if you were to give somebody like a Beck depression inventory where they have to choose between all of these options. The geriatric depression scale is like yes, no, which is kind of similar to like the audit versus the Mass G, which is just yes, no.
Yeah, and the measurement scale keeps changing as well, doesn't it? Like last 2 months, 2 weeks, a year, and then
Yeah.
it's two or three drinks. Yeah, yeah. Okay, that makes sense as
Mhm.
well. Yeah. Thank you so much.
Yeah, absolutely. And these just, again, you still would need further assessment with these. These are just like screeners to
Yeah.
say, like, yeah, this person probably has some risky drinking going on. We should probably figure out
Yeah.
something or resources, just
I think
raise a
we're
red flag.
coming from an angle of we want to try and avoid over assessments in people because they get quite fatigued.
Hmm.
Especially if they've been criminal justice involved, they just don't want to talk about it anymore.
Yes.
So we're trying to like get the best results at the first assessment. But yeah, it's you would obviously do another assessment, wouldn't you? So
The cage is only four
yeah,
questions, yes or no. Uh, it's developed by the American Psychiatric Association.
yeah,
A
I
little
did
bit
write that
newer.
down as well.
But yeah, great questions.
Thank you.
Mhm.
Also, please don't get stressed about the technical difficulties. It's just a bummer, isn't it, when it
It
doesn't
was.
work.
It was very difficult. I'm like, I can't get into this presentation. Save my
It's
life.
fine. It's
We
fine.
are working our way through that.
Yes, thank
It's
you.
it's just a nightmare, isn't it, when it doesn't work? Yeah, I it was great. Thank you so much.
Thank you.
Okay, everyone. Well, thank you for joining us. Thank you, Dr. DiBlasi. Really appreciate it and that gained a lot from this presentation.